You're listening to Healthcare Now Radio. Stand by for This Just In, the latest in healthcare innovation and technology trends with your HIT advisor, Justin Barnes.
Thank you for tuning in, and welcome to This Just In. I'm your host, Justin Barnes. In these half-hour segments, I'll bring you the latest advancements in healthcare, strategy, innovation, and public policy. As always, we're broadcasting from the This Just In studios on the Business Radio X network, as well as the Healthcare Now radio network. And before we dive in with my guest today, I want to take a moment and remind everyone that we'll be broadcasting the This Just In radio show again live from the HIMSS annual conference, and to please stop by the show. HIMSS annual conference this year will be in Orlando, Florida, starting February 20th with 35,000 of your closest industry friends. We already have another great slate of CEO, CIO, leading care providers, industry thought leaders, and certainly policymakers joining the show. Some familiar faces, but many new as well. Much more to come from the HIMSS media team over the next week or two, but we'll do our same two-day format and broadcast live from the HIMSS annual conference show for February 20th and 21st. We're even having a special stage built to resemble the ESPN College Game Day look and feel. So hopefully everyone is registering for HIMSS 17 in Orlando, and you'll stop by the stage at booth 2123. It's guaranteed to be another great, fun, informative time. For this episode, though, my 86th episode, we're going to speak to industry colleague and veteran, Dr. Sanjay Seth from HealthEC. Welcome to the show, my friend.
Thank you, Justin, and glad to be on.
Yeah, it's great to have you. We got to actually sync up yesterday a little bit for a precursor to this show, and you guys just really are a Pop Health Innovator. But before we dive in too deep into what you guys are accomplishing out there in healthcare, tell us, you're new to the show, so tell us a little bit about your background, where you're born and raised, college, all that good stuff.
So I'm pretty much a world traveler, Justin. I was born in England. Then after my formative years, studied in India, went to med school in India, came back to England, and then ended up at Cornell in New York to do my master's in administration from Cornell. And I have been on the administrative side, on and off for a couple of years after that, and then full time. Started my career in the hospital financial turnaround world, and then moved into the physician world, where I think I belong.
Yeah, that's terrific. So, how did you come to helping form HealthEC?
HealthEC, which has a long history of being a technology and service provider for the industry, that started off as a clearinghouse, it came into developing a Pop Health tool and for analytics, and then we're looking to develop the clinical side of the Pop Health program. And that's how we got together. They assembled a team of physicians and nurses to help design the clinical care coordination tool. And that's how we got together and said, that analytics with care coordination is where we need to be.
That's terrific. Yeah, actually, I think I'm going to have one of your partners on my show during HIMSS. So excited to talk to Arthur as well at that point. So, but where does your passion come from for Pop Health?
Well, I think that I have a slogan that says the best business for medicine is good medicine. Mm-hmm. And as we try to address triple aim, it sort of brought that into focus, where if we practice good medicine, the money would take care of itself. And so the motivation comes from providing enabling tools to the physicians or the providers to help achieve that because you need to work smarter, not harder these days, with the changing healthcare environment. So we think technology is a great enabler to facilitate that. And I think that's where it comes from.
Yeah, no, that's terrific. I couldn't agree with you more. So I know we're going to dive into this now, but at a high level, what problem is HealthEC solving?
So once we started developing the tool, we realized that without data, you can't go any further. So we had to take a step back and solve the major issue that the healthcare industry is facing right now, is bringing disparate data into one structured environment. The meaningful use and the IHE and HL7 protocols that the industry had adopted, but haven't been implemented to its fullest extent. So we still have systems that produce or contain data for the same patient, but are unable to communicate with each other. So we actually look to solve that problem first, thus creating a true longitudinal record for the patient, and then the analytics and the care coordination can take over. So that's the problem we are trying to solve today, is bringing all that data from multiple systems into one place. And I think we've been very successful in that. So we look at ourselves as being the plumbers first, and then we can take a nice shower.
That's terrific. So what differentiates you? Because obviously you're in a very crowded space, and I see class and I see you guys are doing well, and it's one of the reasons why I wanted to get you onto the show. I love to highlight innovations. I love to highlight companies as well as executives who are making a big difference, a big impact in healthcare. So what differentiates HealthEC from your competitors?
I think you're right in that it is a very crowded field, and with use of creative marketing, people have been led to believe some things that are not always true. I guess they are the alternative facts of our industry these days. But I think that the differentiation is that we truly bring all the data into one environment, and the ability to take EMR data, claims data, lab data, data from the diagnostic centers, whether it's from the hospital or from a local or regional HIE, bringing that into one place and doing it in a very short period of time is where we are, I think, differentiating ourselves from the rest of the industry. And then a lot of population health tools claimed by different market players do analytics, but cannot bring in the clinical data to include that data into analytics, and don't have true care coordination tools. People are very misguided and seem to confuse the issue of discharge planning or case management with care coordination. They're two different animals, and but it's easy to get confused, and I think there are a lot of companies taking advantage of that lack of knowledge, and certainly marketing helps. So we rarely want to claim anything that we don't do. We only claim what we can and have done. So a good example is we are actually in the process of bringing 660 physicians with, I think, 40 some different EMRs and bringing all their data into one place. And we've been doing it for about 3 months, and I think we've covered about 350 of those physicians already. That's how we differentiate ourselves from the rest of our competitors.
So, yeah, and one of the areas when we were speaking yesterday, and I read some great articles about what you guys are doing, but and what I got really passionate about your business model specifically is how kind of you differentiate some of your markets. You're going after the self-insured, those companies that are taking on more risk. You see that as one of your markets. You see the physician and provider, or the pay rider, as some people are calling them, as they're combining and coming together. So tell us a little bit about some of the markets that you focus on.
You know, with the clinical background and a physician by training, a couple of us in the organization have always felt that enabling the physicians to stay sort of independent or not dependent on a hospital or another health system is really where they need to be, because in this new era of AAA, with a majority of the costs being focused on facilities and diagnostic information, that it becomes a dichotomy for the hospitals to help reduce costs while keeping beds empty. So we think that the physicians need to come together and take charge of their own lives. And that's really what our passion was, in terms of how do we design a system that is physician friendly, that's provider oriented and patient centric, rather than being driven by financial incentives purely. And I think that the organizations we are looking for are those small, mid to mid-sized physician groups that can coalesce together and come together and operate as one, that have spent a little bit of time developing their own mission, vision, and infrastructure. That's the ideal organization for us, because today you need to react to the marketplace relatively quickly. I mean, every month there's a new program coming out, a new value-based, scheme, and I think that we needed to have an organization and a system that is nimble enough, that can react and respond immediately, rather than saying, okay, by the time we develop this program, it's going to be 2019, and by then 5 new things have already come. So that is, I think, where, and sort of protective of our colleagues as physicians. We don't want them to be at the short end of the stick.
No, I agree. And so for those just tuning in, we're speaking with Dr. Seth from Population Health Innovator, HealthEC. So you mentioned, the flavor of the month regarding these programs coming out either from CMS or some of the commercial payers. But what are specifically, because this is where I got very excited, and my heart's been in this space for a long time, looking at all the different initiatives, not only, again, what the Innovation Center is coming out with, but then also what is occurring in our communities from the commercial payers. So what payment and care delivery models do you guys enable today for your customers? Because I got a lot of hospitals that listen to my show, certainly a lot of large practices and small practices, but then also a lot of the influencers to those markets as well. So, and I know people are struggling with all these different models today, but what are ones that you, HealthEC, enable today?
So it comes back to our design of the platform, and the design of the platform was clinically oriented. And what we wanted to do was, what information do I need, and to whom should I be communicating this information? And it came down to being the patient and the provider, or the physician. So when we designed the system, one of the things that we had put in, that I want to see how we are doing as an organization by patient, by provider, by panel for the provider, as well as by diagnosis. Because maybe I'm managing the diabetes differently between 2 physicians. So once we did that in the design, when CMS announces or has announced a program, for example, they announced in the middle of last year this oncology care model, all it for us, all it took was to say, okay, we can do this by diagnosis and limit it to looking back or looking forward to 90 days. Because of that, we certainly do population health. We accommodate the OCM. We are already accommodating the joint replacement. We have episodes of care already built in. And if you take it a step further, we are in an individual's practice for CPC. And what we see CPC as is a ACO of one provider or one practice. So the system is already ready to do all of these things. We haven't seen anything come from CMS that we can actually sort of package and promote within a couple of months. So yes, we are currently the system accommodates all the bundling programs CMS has announced, both in and outpatient as well as a combination, including the SNF providers. So we have that ability to deliver any innovation that CMS has announced. And with the commercial payers are just following up on or following what CMS's lead is. So, and the key to all of this is the disease registries. So once we map the ICD-9 and ICD-10 and create that disease registry, anything is possible, because now with modern day database architecture, we can go slice and dice that information anyway. And we were forced to do some of this because we are a PQRS and a GPRO registry too. So we had to have these capabilities down to the individual physician level with anything possible. So I think we've brought all those features, including our history as a clearinghouse, into the platform that makes it comprehensive and nimble at the same time.
So I agree. So who's a typical customer for HealthEC?
As I said, that we are looking for a provider organization, hopefully led by physicians like they should be, and that has a couple of years under its belt in terms of culturally and emotionally bringing all the providers together, with good clinical leadership and some administrative support, that we come in and solve their technology and their contracting issues. That, I would say, is our ideal client, somewhere between 50 and 800 physicians, with or without a hospital as a partner, but led by physicians, because the system makes more sense to them. So that's, I think, our sweet spot.
Yeah, and this is again why I want to have you guys on the show this week, is we have so many strategies and just the way we think through healthcare, just where and how we feel healthcare should be led. Again, I love what you guys are doing. So in our conversation yesterday, which really prompted today's interview, you talk a lot about CINs, clinically integrated networks, and IPAs. So why is it necessary to become a CIN when a lot of groups are IPAs already? What's the important aspects there?
See, the history of the IPAs is that the IPAs formed so that they could get together and negotiate a better deal with the payers or with an entity. More recently, the FCC has said that you simply can't get together to negotiate. You got to have a more meaningful organization. And what they saw were that the organization had governance and it had, a format to engage the providers, select who they bring into the picture, and then came the difficult part, sharing financial and clinical data on common patients, putting in performance metrics, which is now this new MIPS and quality reporting tools that or metrics that have been released by CMS, and then bringing in standards of care so that there is some consistency amongst all the providers. So that that is why an IPA needs to transition itself from simply being a group that went out and negotiated, and it was called the messenger model, to being a truly integrated group of providers. And that has become the standard that doesn't violate what the FTC thought was casual get-togethers of physicians to do collective bargaining, in some respects. So that is why a CIN is necessary. Now, they are known by a lot of names. If you're in New York, they might call it an organized delivery system. Somewhere else, they might call it an IPN or an IDN, an integrated delivery network. Either way, they need to be more than a group of people just getting together to negotiate with the payer. And I think that's why it needs to be. And the technology that we have sort of forces all of those elements that are required to be a CIN, and truly shares clinical data on common patients. I mean, that is something that, without having to call the consultant and say, can you send me the report? You don't need to do that anymore. It's already in the system,
Yep.
That's what I feel is necessary.
So we've got a couple minutes left in the show, but obviously, back in the 90s, we were working on IDNs, integrated delivery networks, and you mentioned that, and so I kind of understand this, but certainly for my audience, and maybe I'm going to ask you about the technology barriers to becoming a true CIN, because we've been working on this for 30 years, and in healthcare, 40 years. We're really trying to create these integrated networks. So what are as you see today in a landscape, and obviously you guys enable some of this, but what are the major technology barriers to becoming a true clinically integrated network, CIN?
So two things. One is if everybody was on the same medical record or EMR and billing system, it would be a piece of cake. And the difficulty we have is that these systems sometimes are extremely exorbitantly unaffordable for the individual provider, which is why products, Practice Fusion, Cario, people like that who are offering it for free based on advertisements and other things, came into being because the physicians didn't see the need to spend that much money. So the difficulty we see are in an organization, there is no more the need to switch everybody's EMR. And that's, I think, the biggest barrier that most CINs that have started have undertaken, is to force that. And I think we see that as the biggest barrier to creating a large enough group of providers covering a big geographical area or a region coming together if you're going to force them to change systems. So I think technology-wise, that is one part. The second part is each of these smaller EMRs, although they are all certified to do meaningful use, haven't quite implemented a comprehensive protocol to communicate with each other. And I think that's the other barrier that we see during our implementation. One thing is to bring all the appointment systems together. Then you're talking about bringing all the clinical records together. Then you're talking about bringing all the lab systems together, because each provider may have used a different lab for the same patient. And so that information is now, in different forms. So we see that that's the big technology barrier that we have certainly helped overcome to some extent. It's not a perfect world yet, because all the data is still not in structured formats, but the ability to take both structured and unstructured data, bring it into one place, at least that it's viewable, readable, and analyzable, if that's a word. That's really where we think that the technology comes into play. But there are two other things that are very important with that. One is culturally, and two is willingness. There's a lot of politics involved. So if we can overcome some of the cultural and the politics, the technology will move much faster, in our opinion.
I agree. So we're running at the top of our time here, but a couple more questions real quick. Will I see HealthEC in Orlando in February?
Yes, absolutely. We are in the Population Care Management Knowledge Center at HIMSS. We are in booth 6179. So 6179. I think it's kiosk number 12. But yeah, and our CEO will be there with some of our other members. I'm unfortunately in Denver meeting with a large group of providers on the same days. So, but yeah, they will be there, and we'll be happy to entertain questions and maybe even come and see you at your booth. So.
Oh yeah, well you're going to come actually. I know Arthur Kapoor, your CEO, is going to be on my radio show on Tuesday. So yeah, that's fantastic. So in closing, I always ask this question of my guests. It's actually becoming the most show its own now. But what's your favorite place to get or be inspired?
Justin, and you've seen me, and if my picture was up there, people would understand this better. It's food. It's food. It's the kitchen. I live to eat. And, when you're cooking, you have to be super organized, and I think that helps me relax and plan for the next day as well. And I think that's really my passion.
No, I understand, and as we discussed off air, I have the same passion. We're kindred spirits in that regard. It's where I go and relax is my kitchen, and I love to cook. Well, Dr. Seth, thank you so much. It's great to have you as my guest today. So
thank you so much, Justin, and look forward to seeing you again.
You got it, my friend. And thank you to everyone for joining the show today and listening. Please tune in weekdays at 2:30 p.m. Eastern, 11:30 a.m. Pacific. And as always, you can track me on Twitter at HITadvisor and use the hashtag #ThisJustIn so we can respond to your comments from the show. In addition, all my content is always posted at justinbarnes.com. Thanks, everyone. Have a terrific week, and we'll see you at HIMSS. Stop by the show.